So I would like to thank the organization for the opportunity to present our work on the classification and guideline for complaints of the arm, neck and shoulder. And in short, I will use the abbreviation CANS for that, so you will hear that a lot in this presentation. I present this work also on behalf of my colleague Anita Verlees, and with regard to the multidisciplinary guideline, also on behalf of a large multidisciplinary team consisting of 21 experts from 12 professional organizations and 5 Dutch universities, as well as 2 representatives of patient organizations. I don't expect you to read them all. In 1 year, over 1/3 of the Dutch adults report CANS when asked in population surveys. So that's a big, huge prevalence. In the Netherlands, over 10% of all sick leave days are attributed to CANS, representing compensation cost of over 1.5 billion euros. So it is very important to develop more effective treatment options for this patient group than we apparently have available right now. But what is the problem with CANS? In the region of neck, shoulder, arm and the hand, there are many possible diagnoses, some of which are hard to determine. In addition, there's a fair proportion of patients with complaints that cannot be related to a distinctive diagnosis. And for this group of complaints, many terms have been proposed, such as repetitive strain injuries, cumulative trauma disorders, or upper extremity disorders. And in most cases, these terms have been mixed up and combined with diagnosable disorders that are also associated with, for instance, repetitive strain or cumulative load, such as carpal tunnel syndrome or lateral epicondylitis. And also, many classification systems have been developed. In a review by Van Eert in 2003, 27 different systems were found. However, not one of them is broadly internationally used or even nationally maintained. In the Netherlands, in the first decennium of this century, the term repetitive strain injury became popular, especially in the occupational context. However, many medical and paramedical professionals were unhappy with this ill-defined term. There was no clear description which disorders are included or excluded. So, in the Netherlands, and I think internationally, we had a situation which resembled the building of the Tower of Babel, a story I hope you are familiar with, here depicted by the Flemish painter Pieter Bruegel. People talking different language and not understanding each other are not able to achieve a common goal. And in CANS, this is recovery or at least better outcome for the patients. And as Keith Palmer recently stated, disagreement over diagnostic classification hinders the interpretation and effective pooling of research data and contributes to variations in clinical practice with the possibility of suboptimal care. So this is why in the Netherlands in 2002 we started a project aiming at the provision of more clarity in the terminology and classification of CANS. And after that, in 2009, we started with the development of a multidisciplinary guideline in order to gather the best available evidence for diagnosis and treatment for CANS. But at first, in 2002, we composed a multidisciplinary working group that developed the new model for the terminology of CANS through a Delphi consensus procedure. And here you see the model that we came up with in the Dutch publication. I don't know, oh, here it is. And it's also published in 2006 digitally online and 2007 in Occupational and Environmental Medicine. There was overall consensus to formulate a broad definition for CANS in which systemic and traumatic disorders were excluded beforehand. And under this definition, well diagnosable disorders that are called here the specific disorders are distinguished from disorders that are non-specific by nature. And this model is now well implemented among medical and paramedical professionals in the Netherlands. And I will show you the model in the next slides. There are 4 steps to be taken. First, First, we want to exclude the disorders that have the complaints of the arm, neck, and shoulder as a symptom of a more systematic disease. So the systemic disorders or malignant diseases, heart diseases, etc., that cause complaints in the arm, neck, and shoulder region, but are really other diseases. So at first you want to exclude those disorders from the model, and you want to list the symptoms that can relate to these disorders, and we call them alert symptoms. So in the second stage, we want to exclude the disorders that have a trauma as origin, a trauma as cause of the disorder. And it can be acute trauma, but it also can be a longer result of the trauma, such as in complex regional pain syndrome. So after doing that, you have the definition we came up with in this consensus procedure of musculoskeletal complaints of the arm, neck, and shoulder not caused by acute trauma or any systemic disease. The next step is to look at the specific diagnosable disorders that you can distinguish in this group of in this broad group of disorders. And in the model we published in 2004 and later in 2006 and 2007, we had a total of 23 separate diagnoses of diagnostic categories that were formulated in this model. And I won't go through them all. You can read them in the presentation, but you can see that there are diagnoses like carpal tunnel syndrome, Cravens disease, rotator cuff tears, etc. But I noticed that still avascular necrosis of the shoulder is not one of them. So, of course, there are more diagnoses out there, and we have to extend this list of diagnosable disorders. And if you exclude all these diagnosable disorders, you come up with this rest group of patients that have complaints that you cannot relate to a specific disorder, and those patients we call to have non-specific cons. So what I said, you have to extend the list, and that's what we did as a first step in the development of the guideline for arm, neck, and shoulder complaints. We looked at this list of specific disorders, and some disorders were excluded from the list, mainly because they were either thought to be caused almost exclusively by trauma, such as complex regional pain syndrome, or to systemic disease, such as Raynaud's phenomenon, or were thought to be a sort of outdated diagnosis, such as Osmond's rust. But also there were added, we added 15 diagnoses or diagnostic category to this list. So in total, then we had 35 diagnoses or diagnostic categories. And here you see the diagnoses that were added to the list of 2004 to come up to the total list of 35 diagnoses. But I think in future updates, this list will extend a little bit more, so you have a clear picture of which diagnoses should be distinguished. And this is important because these specific diagnoses often also have specific treatments that need to be installed, often by medical specialists or other professionals who are specialized in this kind of disorders. And they have to be distinguished from the non-specific complaints that need different treatment, and that we need to learn more about the effectiveness of treatment for those disorders. So I think the advantage of the CANS model over the other classification models is that it's a comprehensive model for all non-traumatic musculoskeletal disorders located exclusively in the neck, shoulder, arm or hand region. And it includes a well-defined group of non-specific disorders by exclusion of a detailed list of specific disorders or traumatic or systemic disorders. So you know what you are talking about. And if you try to develop research for this kind of disorders, you can have a clear definition of the patient group you are talking about, and then you can draw much more firm conclusions about that patient group. And the starting point is the usual medical model, where complaints or symptoms at a certain location lead to a differential diagnosis that is further reduced by physical examination and, if useful, imaging or blood research. And that's not the case when you have terms like repetitive strain injury or cumulative trauma disorder. It's not familiar to the normal medical model. And these specific disorders can be arranged by location, by affective structure, or by pathophysiological process, or both, so you can have a clear distinction of those specific disorders, and I show you that we did so in the guideline. So now I want to present the highlights of this multidisciplinary guideline for the diagnosis of CANS and the treatment of non-specific CANS that we developed from 2009 on. And of course I won't be able to tell you all the details, but I will give you the highlights of this guideline. For the development of this guideline, we used the EBRO method, and this is the translation of this is evidence-based guideline development, and it's the standardized procedure for guideline development in the Netherlands. And first, key questions are formulated from patient groups and from medical professionals regarding the topic of the guideline, and in this case 17 key questions have been formulated and that are leading in the development process of the guideline. And for each key question, a literature search is done and a review of selected papers is done. So you have a sort of systematic reviews for each key question. And if you want to look at still the Dutch version of the guideline, you can download it from this link. I don't know if we get the presentations. I think so, because I had to hand them in. So you can click on this link. It's in Dutch. I will try to publish it also in English, but you can have a closer look at the details there. So when you have this review of the literature, of course you come up with the conclusions from this literature, but of course you can't answer all the questions you have as a professional from the research that has been done, and especially in the field of non-specific CANS, much is still to be known and to be researched. There's not too much research out there. So there's, and there the multidisciplinary group comes in. There are also a lot of other considerations that are important for the recommendations that are made for each key question. But these considerations first had to go to a consensus procedure so that everyone in the multidisciplinary team agreed about these considerations that are taken into account for the recommendations. And then we have recommendations based upon the conclusions from the review and this consensus in the development team. So first we looked at the diagnostic process, one of the key questions. Well, we used the CANS model as a starting point, I told you about, and then we gave an evidence-based overview of the diagnostic process from medical history, physical examination, the physical tests that are useful for diagnosis of these specific disorders, and additional imaging or blood research. And the goal of this diagnostic process is to determine one of the specific disorder or to exclude all specific disorders resulting in the diagnosis of non-specific CANS. We did, and after that, we came up with recommendations for the treatment of non-specific CANS. We didn't come up, due to time and budget constraints, with recommendations for the treatment of all these different specific CANS. For some of them, also guidelines are out there, but for some of them, they have to be developed still. So this is an example of the diagnostic tests we included in this guideline, and I will enlarge this bit so you can have a look at how we came up with a scheme for the diagnosis and for the use of physical tests for the diagnosis of the different specific disorders. And we included only the tests that had sufficient sensitivity or specificity to contribute to this diagnosis. So all other tests that didn't have enough evidence for sensitivity or specificity, we excluded. So in the region of neck, shoulder, and upper arm, for instance, for the diagnosis of cervical radiculopathy, you can use the Sperling test, the neck traction or distraction test, the Valsalva maneuver, or the upper limb tension test, that really contribute to make this diagnosis. Of course, as a professional, experienced professional, you can also use other tests that you have much experience with, but we advise in the guideline in any case to use these tests to come up with such a diagnosis. And then you can have other methods, MRI or EMG or imaging, to confirm this diagnosis. And also the recommendations about that are evidence-based from the literature, but there's not extensive literature out there for that. So in that way, with the physical testing and the additional diagnostic interventions, you can either diagnose one of the specific disorder or exclude all specific disorders as much as you are able to, and then come up with the diagnosis of a non-specific disorder. And first, before we went on to the effectiveness of treatment for this non-specific cons, we looked at the patient profile for this patient group, because it's important to know that the patient fits the profile for the treatments that you would recommend. And of course, they have complaints in the neck, shoulder, upper back, arms and or hands. And this can be pain, stiffness, numbness, tingling, etc. It should not be caused by trauma or systemic disorders, and specific cons should be excluded as much as possible. But the team added to the profile a clear relation to work or activities, because if there is no relation in the course of the complaints or the follow-up, so the cause or the course of these complaints, you should look further for a specific disorder, because that's abnormal. If you have non-specific cons, almost always there is a relation to work or to activities like sports, etc. So then we looked at all the treatment options that are out there for non-specific cons. Exercise therapy by physiotherapists or by other therapists. In the Netherlands we have Mensendijk and Caesar therapists that you can involve. Other physiotherapeutic interventions such as manual therapy, pharmacological interventions, anesthesiological injections, psychological interventions, multidisciplinary pain rehabilitation programs, occupational therapist and ergonomic intervention at work. We didn't look at surgical intervention because we thought for non-specific cons this wasn't relevant, because what would you like to operate? So, sort of summary of all this review of effectiveness for the treatment options, I will give in the following slides. First, we looked at the exercise therapist by physiotherapist or other therapist, and for this treatment option, there's the most evidence out there. For the patient group that had work-related cons, we found 4 randomized trials yielding a high level of evidence of positive effects of exercise therapy for this patient group. For the group of non-specific neck pain, we found 6 randomized trials also yielding a high level of evidence. For non-specific shoulder pains, there were 3 randomized trials yielded much more limited evidence for positive effects. And there were 9 randomized trials comparing various types of exercise therapy with each other and didn't find any difference between the various types. Similar results you can find for back disorders, for instance. Except in work-related cons, strength exercise seemed to be a little bit better than endurance exercises. So with regard to manual therapy, there was limited evidence in the literature for positive effects. Mobilization was not more effective than manipulation, but if you look at the one or the other and compare it to other treatments like pain medication or usual care, it seemed to be a little bit better in the short term. So it's not a very firm conclusion, but there seem to be some indications that it can do some good. But the combination of manual therapy and exercise therapy was more effective than either therapy alone on the short term. And in the long term, it was equally effective than exercise alone. So, especially for the short term, you can add manual therapy to exercise therapy to yield good results. Manual therapy of the C7-T1 junction or the costovertebral joints was more effective than regular physiotherapy or usual primary care for non-specific shoulder pain. So for that patient group, it might be an option to have this kind of manual therapy. With regard to work-related interventions, we found 6 randomized trials looking at ergonomic optimization of the workplace. and yielding a good level of evidence for positive effects of this intervention. If you look at frequent short breaks, there were 2 randomized trials yielding limited evidence of positive effects of that intervention. And if you look at personal interventions such as stress reduction, relaxation techniques, or intervention of work style, there was very limited evidence, mostly 1 trial that was out there with positive results. For all the other treatment options, for non-specific count, there was very limited or no evidence available. But I should indicate that for psychological interventions and multidisciplinary pain rehabilitations, from the other considerations of the development team, they were, although there was not enough evidence in the literature, they were included in the final clinical pathway that we formulated for these disorders. So, but that is based on consensus of this multidisciplinary group, and it's not based on evidence. So, and in the guideline for the Dutch professionals, we clearly state that it's a consensus recommendation and not an evidence-based recommendation, because there's a clear difference in that. So here I show you the clinical pathway for the treatment of non-specific counts. I hope you can read it, but I will guide you through it. In the first 2 weeks of complaints, the advice is to do almost nothing, to give education, to give advice, and do nothing at all. Wait. And if the complaints persist after 2 weeks, then a patient can come back and you can look at the other options. But in the periods of 2 to 6 weeks of complaints, the only intervention we added is to, in case of work-related counts, in case there is sick leave or in case there is reduced productivity or problems at work, we advise to consult the occupational physician and to have, for instance, ergonomic interventions at the workplace. No other interventions are advised. After 6 weeks duration of complaints, the treatment option of exercise therapy is added as an evidence-based treatment option. And here the development team added that in case of clear psychosocial problems, you can consider involving a psychosomatic physiotherapist. That's a specialization in the Netherlands of physiotherapy. So that's a physiotherapist who has more attention for the psychosocial problems, or to add a psychologist to the sort of multidisciplinary team you use in primary care. So, and of course, the work-related, for work-related counts, you still advise to involve the occupational physician, and you give education and advice. If complaints still persist 2 to 3 months after the start of effective therapy, and that is exercise therapy, then the recommendation is to reconsider the diagnosis, because, of course, in time there can be signs or symptoms that come up and that or that have been overlooked before that indicate a specific disorder. And of course, then you have to follow that course and maybe involve a medical specialist in further diagnosis of the problem, because clearly then something is not how it should be. But if there is no indication for specific diagnosis, the recommendation is to look if there are barriers for discovery, for recovery, or if there are many psychosocial problems, to have an intervention by a multidisciplinary team. So here the recommendation for a multidisciplinary rehabilitation intervention comes in, even though it's not evidence-based. So, and then, of course, you hope with the several steps that the patient recovers and that eventually there is a limited group of patients who didn't profit from the treatment options that were given. So, in conclusion about this guideline, the starting point is the Kant's model. I explained that it's the diagnostic framework for the classification of the disorders of arm, neck, and shoulder, and offers the opportunity to make a well-defined diagnosis of non-specific counts by exclusion of these 35 specific diagnoses of diagnostic categories. But the diagnostic criteria and the knowledge about validity of physical tests is still insufficient for correct determination of the diagnosis of most patients. So we still have to do much work, much research to come up with better methods for the diagnostic process. And until now, of course, non-specific cons is insufficiently defined so in research, which hampers conclusions about effectiveness of interventions, as Palmer stated before, I showed you before in one of the first slides. But although much research is still needed, the guideline and future updates can be useful to improve diagnostic interventions so that patients with specific cons get better targeted treatments. And knowledge about the outcomes of interventions for well-defined non-specific cons improves decision-making for more effective treatments, resulting in more patients receiving the best treatment. So that is what I wanted to tell you about the development of the cons model and the guideline. Thank you for your attention.
Any questions? Any questions? No? I believe we have a coffee break then.
I have a question for you, Dr. Miedema.
Yep.
So is this tool being used for primary care physicians, or is sort of that the goal? And then 2 is the implementation of it, has it facilitated, are you looking at the consequences of what the impact might be once you've implemented the model?
Yeah. Thank you. Yes, it is a guideline. It is the development is multidisciplinary, so also medical specialists, etc., looked at the guideline. But of course, patients with a limited duration of complaints first come in primary care. So it's mainly a guideline for primary care physicians, general practitioners, and physiotherapists who are the first to see the patients and who are the first to distinguish between these specific disorders that may have to be referred to medical specialists, or non-specific disorders which are primarily treated in primary care. They don't have to be referred to medical specialists. And then the guideline says when the most effective treatment options are implemented but fail to have effect, well, then you can consider either for the diagnosis to involve a medical specialist, or for patients that fail effectiveness of treatment to have a multidisciplinary rehabilitation intervention. And your second question was if we have a structure for implementation of the guideline. The various professional organizations that were involved all have their own sort of structure for implementation. They have an approval procedure. So they all approved of this guideline. They have the procedure of disseminating the knowledge of this guideline to the professionals. Sometimes they also do various conferences or workshops. But I have to say, often budgets are limited, and so the implementation efforts could be much more. And we also don't have a method of evaluating the effects of implementation of this guideline.
Do you foresee it's supposed to improve resource use? Is that sort of the idea in standardizing this type of thing? Because in the United States, there's clear abuse or uses and push toward guidelines because of the over-ordering and the number of referrals. So the resource, I think it's something for cost-based. I think you started with cost. That was sort of the impetus of it, or is it a goal of it?
Yeah, that's of course one of the goals. The other goal is that there are too many patients not recovering with non-specific complaints. So there should be no reason why they don't recover, but they don't recover, and they are the cause of huge cost of sick leave, etc. So that is also one of the reasons. And the other reason is to give more clarity for the professionals how to distinguish between non-specific and specific disorders.
What was the incidence of specific and non-specific cases?
In the Netherlands, we did a cohort study. In that study, it's about 60% specific disorders and 40% non-specific disorders. So the group of non-specific is really large.
What are the chances of non-specific diseases ending up in a specific disease?
Well, that's a difficult question because then you have to have long-term follow-up research. So I should answer you, I don't know. Of course, in first stages of the disease, you can overlook a specific diagnosis. And if you don't know where to look at, so you don't know which 35 or 36 or 37 diagnoses you have to look at, then you may overlook some causes, and then, well, in the long term, mostly, well, you have signs and symptoms that, and then you know it is a specific disorder. But there's no follow-up research on that.
One more question is, what is
That's also a difficult question. You have certain types of professions where the incidence of these kinds of complaints are higher, especially computer workers, and that's mostly white collar, but also in industry, people working at doing repetitive work in line work in industry, also a big cost. So it's a little bit of both. So you have to look at the type of activities people are doing.
Posture plays a major role in non-specific cases.
Posture, he said.
Posture, yes, and repetitive strain and combined with excessive loading, that results in non-specific complaints.